This is Carol from the STS. This is the Adult Cardiac Surgery Database webinar for April 1st, 2020. This is our monthly webinar. We have quite a bit of updates for you all and getting out some information. I know everybody is under a really stressful time right now, so I appreciate you taking time out of your day to join. I know everybody is working really hard and stretched thin, so thanks so much for joining. Just please, if you could please, this webinar is going to have a lot of information in it. I just ask, we're probably going to get to your questions during the webinar. If you could just hold your questions more towards the end, and I'll be happy to get to them. But again, I know everybody is anxious about things that are going on and how we're going to manage the COVID-19 as we're going forward and seeing some hospitals really stressed out. So we'll get to those questions very, very soon, but just hold them for the time being. And also, please enter your questions into the Q&A instead of the chat box. That way we can keep track of them and answer them as we see them coming in towards the end. Thank you. Again, it's myself on the phone. We have some STS staff, so we have our IQVIA team, and I think we're pretty good here with the people we have on. Thanks again. Here we go. So then the housekeeping, important dates, and then a COVID-19 update. I'm going to go over range values, the ProcID chart, and the risk model variable chart. If we do not get to the ProcID chart and the risk model variable chart, we will get to these on the next webinar, but I would really like to get to them today, but we'll see how many questions we have towards the range value area, and then I want to leave enough time to get to your concerns. So some housekeeping. We have the data spec upgrade is underway. The vendors are all working very hard on getting their data specs updated and working towards certification. I do have a polling question. We know that sometimes version go lives in the middle of a year is obviously not ideal, but because of our transition to IQVIA, we've had to kind of finagle timing around. So we are planning to go live with the version 4.20 update on July 1st. But I do have some questions to find out because our STS leadership wants to make a very thoughtful decision on how we move forward with the upgrade. So I just want to poll the group and kind of get a feel for what your thoughts are on these things. So if you could just all vote. The question is, if version 4.2 needs to be delayed, when would you prefer it to start? The first choice is right away, we don't see any issues with it. 10.1 would be fine. Keeping in mind that this version is going to have a 30% reduction in fields, which will definitely decrease the burden at your site. And also keeping in mind that on January 1st, we are going to go live with the general thoracic upgrade version, which will have significant changes in the postoperative complications section, which we're still working on. So for sites that abstract for both of those registries, I just want to make that, be transparent with you on that. I know people are still voting, so I'm just going to wait here. And we also realize for sites that do their own analysis on some of their data, that October probably would not be ideal, but perhaps other sites would feel differently. Okay, so it's pretty torn between going live on July 1st and going live on January 1st. So I think we'll take that into consideration as the leadership is making decisions on that. Here are the results for that. So thank you. The April training manual has been updated. Most of you should have received notification today that we have added a field in regarding data capture for COVID-19. The training manual has that information in it. The new DCFs have been posted for version 4.29 to have that field. I will go over that in more detail. For AQO, regarding AQO in September, we are currently evaluating that in leadership, so we will be communicating out to sites as soon as we have any further information to share on AQO. The next slide is, this is our important dates for adult cardiac. So we're here on April 1st. We have our monthly webinar, and then our COVID-19 field had been added. We have a user group call on the 15th, the spec upgrade call on the 30th. We are expecting the bidirectional data exchange to provide us data back from DCRI with your analyzed data sometime in April or May, and we'll communicate out when that will come. As we get closer to those dates, we'll communicate out. And then we have our next monthly webinar is May 6th, and then our tentative go live date, or hopeful go live date, what we're aiming for is July 1st, still being evaluated for version 4.20. And then August 21st is the harvest close for Harvest 3, which will combine Harvest 2 and 3, and I'll get more into that in just a second. I have a couple questions here regarding COVID and how it's been affecting you. We are all going through this. It's a brand new thing for all of us. So we don't know what you're going through at your site, and we just really want to understand better how this is impacting you. So I have two questions here for you, if you can see them. The first question is, oops, sorry about that. The first question is, has your role been affected related to COVID-19? And the choices are, my role has not changed. I've been pulled from 100% abstraction. My workload has slightly increased to PRN bedside care, so you're just going to the bedside as needed. You've been assigned other roles outside of outside of bedside care, but you're assuming other roles, or you've been furloughed, because we've been hearing from some sites that because their CAS have been canceled, they are no longer, abstracting for CAS PCI. So we're also not seeing surgical patients come in because we don't have CAS for those patients. So that's kind of where that answer had come from. So it looks like for most, for that question, their role has not changed. And then the next type of question is, what types of procedures is your hospital performing? All electives are still being performed. We have limited our cases to only urgent, it should say urgent emergent, and our CVOR is shut down. We are not performing any cases at this time. Okay, so it looks like most, everybody has, I'll share these. I'm going to stop. I think we have quite a few in. And I think good enough to make an assumption we have, or make a decision we have. Most people's roles have not changed, and they're limited to, your hospitals are limited to urgent emergent cases. So thank you for that. Next slide here. So this is what has been added to the data collection form for version 2.9. We have these temporary fields that are built with every version, and these temporary fields are intended to only be used as instructed by STS for occasions like this. This is the second time, I think, in 10 years that STS has ever had to use these temporary fields, which is really good. However, when we went to go use it to collect this extremely important data, we found that cases that these fields had been used over 20,000 times, that there was data in here on 20,000 different cases for version 2.9, which means that somebody or some buddies are using these fields as not instructed by STS, which makes it hard when we have instances like this where we really need to collect emergent data, almost impossible. But thankfully we have these extra codes here. So we skipped down to using code 10, 11, 12, 13, and 14. The question is, did the patient have a laboratory confirmed diagnosis of COVID-19? These patients, in order to code yes, the patient has to have a laboratory confirmed diagnosis, and the choices are no, yes prior to hospitalization for this surgery, yes in hospital prior to surgery, yes in hospital after surgery, or yes after discharge within 30 days of surgery. Your vendor software, your vendors have been notified to add this in. We sent the email that you had all received out to the vendors as well. They have been notified to add these choices in, but this temporary field is still available. You will just need to code the harvest code and recognize that if you're going to code no, you need to code harvest code 10 for this field. Yes is harvest code 11, and so on. So we're using, make sure you use these harvest codes 10, 11, 10 through 14 to code this. And if you are using these fields for any of these temporary fields for your own site, please stop using them, because we need to use these for emergencies like this at the STS where we really need to get this data in. So I just wanted to share that. And then here's some more, did I skip my slide? Here's some more information about abstracting these fields. Why did we add this field? Well, sites have reported, we've heard from numerous sites, especially in the New York area, that they have taken patients to surgery not expecting that patient had COVID-19. The patient did well, ended up getting extubated, did well for the first couple days after surgery, and then day 3, 4, or 5, they had a very bad turn for the worse and went into acute respiratory distress. So we are recognizing, we are hearing from some pretty horrifying stories coming out of these hospitals about their patients and what's been going on. So the surgeon leaders at the STS felt that it was extremely important to start collecting this data as soon as possible. In the mail that went out, it said that to go back to January 1st. So we know that COVID-19 had been present in Washington in January, so we know that the West Coast had been affected since January. We're allowing those sites to go back, or we're asking those sites to go back, and if they know of any of their surgical patients who had tested positive for COVID or anytime pre or post, to code that as this is allowed to go back to January 1st. You only need to code this, only need to go back and re-abstract this field if it's really something that's happening at your site. Going forward, I would ask that this is coded on all patients starting with April 1st cases. I would never ask, and STS would never ask you to go back in a time like this and re-abstract all of your cases. So if you leave this no, it will default. If you leave this missing for those cases, it will default to no, just like how all of the other fields, if you leave them missing, they default to the lowest value, lowest risk factor score. So it's important to have this field available for sites that it is impacting. So that's where that stands. And then will these patients be included in outcomes? STS is in discussion regarding how these cases will be handled. So we have a couple calls going on behind the scenes with leadership. Our quality metrics task force chair, Dr. Shahan, and other chairs of different task forces, talking about how we're going to handle this. But what's the most important thing is right now is that we just need to get the data in. So we can't make any, I don't think we can really make any real big decisions about how we're going to handle this without data. And we just need to start getting that in and seeing what it's looking like to really make a good decision. And then, can I abstract a patient who is assumed to be COVID-19 positive but was not tested? No, only code yes for a patient who has been confirmed to have a COVID-19 diagnosis through laboratory testing. We cannot assume based off of symptoms that the patient has COVID-19. For purposes of our databases. In healthcare, they can do that because the same treatment, social distancing and isolation is the same if you have the flu or if you have COVID-19. Unless your situation gets worse, then they would probably test you, or if you have more risk factors, they would test you. But so for purposes of surgical patients, for our surgical patients, we need to have a laboratory confirmed diagnosis. All right. So we sent out another email, I think it was later last week. I think it was on Friday. And we talked about combining Harvest 2 and 3. We talked about public reporting, and we talked about go live for July 1st. Or we didn't talk about go live, but from this email, we had some questions about what's going on with July 1st go live. I had asked already about your thoughts on it. There was kind of a 50-50 between July 1st and January 1st. So we'll take that back. Now, regarding Harvest 2 and 3 combined, we have canceled, I guess you could say we have canceled Harvest 2. Harvest 2 was not a star rating period. You would have gotten your outcomes updated on the IQVIA dashboard, but because of everything that is going on at sites and the stress that sites are under, the STS leadership had decided that it's best to just cancel this Harvest and just go with Harvest 3, which the deadline is August 21st, 2020. That it includes OR dates through June 30th, 2020, and it is a star rating report. As any of this information is to change, we'll obviously communicate that out. Public reporting for 2020, there will not be a refresh of the public reporting results on the STS website in 2020. So what your results are now is what's going to stay up there unless you rescind and you pull them down. The next public reporting refresh will be January 2021, and sites will still receive a star rating for their 2020 data. It will still be in your reports, but it will not be used for public reporting. The adult cardiac audit update and poll questions. Oh, I have a poll question. That's what that meant. Sorry. Hold on. Let me find it. There we go. Okay. This is an update on the audit, our status of the 2019 audit, which was on 2018 data, and this year's audit, which is on 2019 data. For last year's audit, CRS is still completing their evaluations. CRS is the company, the audit firm that we have hired to do our third-party evaluations, and we're expecting reports out to sites by May. For the 2020 audit, which is on 2019 data, the STS surgeon leadership is evaluating the feasibility of performing that audit and any types of adjustments that may need to be made related to the COVID-19 and impact on sites, and then we will communicate out to sites as soon as possible with next steps. I do have a question about that, and here it is. What is the time resource needed for sites who have had to been audited, or if you haven't, just answer that you have not been audited, but what is the time resource needed to perform the audit at your hospital? This will be okay. All right, so it looks like it seems for those sites that have been audited, here, let me share the results with you. For those sites that have been audited, it seems that it's either a moderate or a substantial amount of time. So this is something that we can share with STS leadership as they are contemplating next steps for the audit. Okay, and then on the last webinar, I apologize. I think I spoke too fast on what came out of my mouth was the words that were 3 steps ahead of what I meant to say. So T-bar cases do belong in the STS. TAVR or TMVR cases are optional. They belong in the STS ACC TVT registry. They are not required to be put in the STS ACSD registry. You can, it is optional, but not required to go into the ACSD registry. So I hope that clears up that question. And now let me see where we're at with questions here. Okay, I'm gonna see if I can get through this. How are we doing on time? I'll probably talk for about another 10 or 15 minutes and then we'll go to questions. For range values, whoops. Apparently my scrolling on my mouse works on that side too. The range value question. So I believe this was a January webinar where we had talked about range values and, hold on one second. Where we had talked about range values and we had talked about low values, high values, and usual range values. And there was some, I think, confusion on what is acceptable into the database and what is not acceptable into the database. So I just want to provide a little bit more clarity on this. I took INR as an example because we have all of these values available. And this is in the training manual, but I kind of wanted to walk through it. Hold on one second, sorry. Okay, so we have, I used INR as the example. We have all 4 of these values available, and I laid it out in a line here. And I think this will be a little bit better to read. We have our low, the very low and the very high values here. So this corresponds with low values and high values. You can see that anything below the low value is not allowed. Anything above the high value is not allowed. The yellow and green within this is allowed. into the database. If you have, it will show a warning on your data collection, but it will not exclude that data from that file from going into analysis. So you have this is the usual range, which is normal on a lab. If you get a lab result back, you would see these listed as the usual values for that, expected values for normal. That's what the green is. The yellow ranges are ranges that we consider to be slightly abnormal, but not too abnormal to be accepted into the database. The red ranges are ranges that are very alarming because they are so far outside of the normal range that we would not want those in the database. If you have values that fall below the low or higher than the high values, you are to enter the low value or the high value respectively. So if you have a value that's 31.00, you're to enter 30 in. If you have a value that's 0.3, you're to enter 0.5 in. That will, the way that the risk models, this has to do with how the risk modeling works. And we have to have some type of end to our data when we do risk modeling. We just can't take in all the values and assume that they're correct. What happens is, even if it is a correct value, we want you to use this very low or very high value. What happens is when they do risk modeling and they look, they can see that you have these very far outliers, which makes the data unusable. So we have to stick with data that is usable in risk stratification, which are these low values and high values. Next slide. So I'm going to go to, I think we have about 40 questions in here so far. I guess we can start taking them. I really want to let me do the ProcID chart because I really wanted to get to that first. Let's see if I can pull it up here without losing too much. I really wanted to get to this because I think it's important to share this with you. So the STS website page. Okay, so this is the 2.9 data collection tools. You all are very familiar with this. If you're raising your hands on your screen, we can't unmute you, so please if you have a question, please put it into the Q&A so we can get to it. So here are your additional resources. We have the changes across time for the thing, and we have itemized changes from the previous version to the most current version, the data specifications, the software specifications, and then further down here we have the ProcID and identification chart and the risk model variable chart. The procedure identification chart is used to assign a procedure code to a procedure that allows it that has a risk model associated with it. So this is how we make the decision at the analysis end onto what cases get analyzed and what cases don't get analyzed, and what cases you would get your O/E ratios on. I'm trying to make this smaller, but it's not going smaller. So I guess we're gonna get stuck with this here. So for instance, ProcID 1 relates to isolated cabbage cases. So what makes a case an isolated cabbage cases, and all of that definition is provided in the column below it. For OPCAB 1, this is OPCAB, we have sequence 21, which is 2120. The choices would have to be yes planned or yes unplanned due to unsuspected disease or anatomy. So let me see if I can pull up. Hold on one second, sorry. Okay, so we have OPCAB 2120. Okay, I want to see what those choices are. So The choices I have here are yes, planned, yes, unplanned due to surgical complication, or yes, unplanned due to unsuspected disease or anatomy. So the only choices that would keep this case in the isolated coronary artery bypass group is if I had chose yes, planned, or yes, planned, yes, unplanned due to surgical complication. I'm sorry, due to unsuspected disease or anatomy. So that would keep it here. Now say that this patient had a scheduled AVR. They had a scheduled surgical aortic valve procedure. And you can see in this row here, this is the cabbage row. Okay, so I had an AVR that was planned. All right, everything went okay until all of a sudden in surgery, we accidentally dissected something. So now this patient had an unplanned due to surgical complication APCAP type. That's going to stay in the isolated AVR category. So for this patient, the patient had a planned VSAV, they had a planned aortic valve surgery, but they had an unplanned due to surgical complication coronary artery bypass. It stays in the isolated AVR. The reason for that is because the way the risk models work is that if it was a complication due to a surgical procedure, during that procedure, it's like a broke it, you bought it type of broke it, you bought it, and you need to fix it, and that those outcomes are probably will negatively impact your AVR, but that is something that should not have happened in the surgery, so it stays in the isolated category. So we'll keep with isolated CABG. We have yes planned, yes unplanned, and then the app valve, it's not used in this calculation. What does that mean? So we don't even look at app valve for this. If you, we don't take that into consideration. That's the field 2125, which is, hold on, it's valve surgery, yes or no. We don't look at that. What we do look at though is the specific valve. So the aortic valve, mitral valve, tricuspid, pulmonic. We look at those valves and what the choices were provided for those. So for for surgical aortic valve, we have VSAV. The choices that would keep this case in the isolated CABG case for this short name and sequence number is no, yes, unplanned due to surgical complication, or missing. So say that they took the patient to surgery for a planned isolated CABG procedure. Something ended up happening to the valve that was considered to be a surgical complication of that coronary artery bypass. It stays in the isolated CABG case and gets assessed with and analyzed with all other isolated CABG cases. Same thing for mitral valve. And then we get down to the congenital procedures. These are what keep it in the isolated CABG case. If anything other is selected, so let's look at 6515. Oh, I have to go to that list. But if anything other than these choices are selected, so PFO closure, primary closure, anomalous origin of coronary artery from pulmonary artery repair, or an AAOCA, if any of these are chosen, it will stay in the isolated CABG case. If anything other than these are chosen, it will get moved over into the other case, to the other category, and will not be analyzed. Tricuspid valve repair, so that we're still in the isolated CABG column. For tricuspid valve repair and replace, unplanned surgical complications only will stay here. And so it's VSTV is no, unplanned due to surgical complication, or missing. I do want to step over. So that's for isolated CABG cases. And then there's a couple of things here that this is kind of new. So the second column is, this is ProcID 2, which is aortic valves. And this third column, or fourth column, is ProcID 3, which is mitral valve repairs, replacements. So this, we're going to look at this third column here with mitral valve replacements. It says, to keep this case as a mitral valve replacement, it says all tricuspid repairs are allowed. So it does not matter if that repair was for a surgical complication or it doesn't matter the reason, all of them are allowed. The tricuspid replacements and valvectomies are only allowed if the tricuspid procedure was unplanned due to surgical complication. The reason why this was, why all tricuspid repairs were allowed was, I believe, for two reasons. The first was because when the risk modeling task force looked at the mitral valve and they looked at concomitant tricuspid valves repaired, they did not see a significant difference in outcomes related to these procedures. That allowed us to keep these cases in so we would have a bigger denominator, which allows for better risk, for better analysis. When you have a larger number, you can look at outcomes a little bit better with a higher number. And then, so I'm going back to the isolated cab case, which is this first column here, and we get to pulmonic valve, VSPV, the sequence number 3685. And so it spans across all of these. This applies to all of the procedures that are ISO-CAB, ISO-AVR, ISO-MVR, and I believe this is AVR, or CAB-AVR, ProcID 4. So this applies to all of ProcID 1 through 4. If VSPV is either no, yes, unplanned due to surgical complication, or missing, it will keep it in the respective isolated column that you're looking at. So that's how you read the ProcID chart. I have about 50 questions in the Q&A. I'm just going to get through this last page. I think it's pretty clear how to read this chart. Now, I hope it's clear. Now once we've gone through it, how to read this chart. We get to, if we're still looking in column 1, we get to, this is ISO-CAB. We're looking at previous VAD explant. This is yes during this procedure, no or missing. We'll keep it in the isolated cabbage column. VAD implant timing. To keep it in the isolated column, you need to have selected preoperative in conjunction with CV procedure unplanned, or postoperative after surgical procedure during reoperation, or if the value is missing. We'll keep it in the isolated column. Same thing with timing 2 and timing 3, and then valve, I believe this is VAD explant. Yes, not during this procedure, or no, or missing. We'll keep it in the respective isolated columns that you're looking at. And then this is the LVA, either no or missing. So if you had other cardiac, I think this was left ventricular aneurysm, if you chose yes for this, for any of these ProcIDs, if you chose yes, it's going to move it over into the other column and it will not be analyzed. Same thing with other cardiac VSDs and then aortic proc. So you did a AVR and you did a aorta procedure. If you chose no, or you did a CAB and aorta procedure, you chose no, or it was unplanned due to surgical complication, it will keep it in the isolated column. If this was if it was a planned aorta proc, a procedure on the aorta, it will remove it over into the other column, so it will not be analyzed. So that's how you read that chart for AFib procedures. If it was lesion, primary epicardial, or missing, it will keep it in the isolated category. If it was intracardiac, it would move it into the other. So you just have to really look at this chart, look at this document, and read along with your data collection form to see what the allowable choices are. If you choose these choices that are listed on here, it will keep it in that specific group. Okay, I'm going to go over to the Q&A now because we have quite a few questions, and I'm going to stop here. The next thing that I had, let me share my screen again, 1 second. So we got through the procedure identification chart. I was going to talk about the risk model variable chart. I would say just look at that. The variables that are checked for each endpoint will correspond. Those are data collection point, data variables that you really need to focus on abstracting and making sure you have good documentation to abstract those. So I'm going to go to the questions now and see if we can get through some of these. I wish I could hear your voices so I could say, is everybody okay? Okay, next question. Does IQVIA have, first question, does IQVIA have a data entry portal that would allow sites to eliminate third-party software? So we will have, IQVIA will have a direct data entry portal. There are some limitations with that. That will It's planned to go live on July 1st, but I think as everything changes, we'll be in contact with as to when exactly that becomes available. That is an option. So next question, is ProBNP the same as BNP? And the answer to that is no, ProBNP is not the same as BNP. We collect BNP in the registry, not ProBNP. Next question, will we be able to obtain our raw data and save it in an Excel spreadsheet for us to extract data as necessary? So I would save, Mark, if you could save this question for our call with IQVIA. I'd like to focus on questions just for this webinar. What if our role will be changing but hasn't? I was just assessing the situation now at your hospital, but we are keeping in mind that everything is changing. Please be transparent and show results of the poll. So I apologize, I believed I did show you the results of the poll. If I didn't, please let me know. I'll be happy to send those out to you. And I'll put my email up on the screen here for you. When did you say the vendors are adding the field? I haven't seen it yet. So we just had final confirmation that the COVID field was to be added yesterday morning. We had updated, Leanne and I had updated our data collection forms for adult, congenital, general thoracic, and our training manuals. We had all of those posted by 8 o'clock last night, and we just sent notification out to the sites and vendors this earlier this afternoon or late morning time. So everybody had been notified at the same time. So hopefully they'll be adding, and I don't know how long it takes for them to add a field, but in the meantime, you're to code using harvest fields, harvest codes 10 through 14. And that's listed on the data collection form. I can show you. Well, that's listed on the data collection form that has been updated on the website. For these survey questions, delaying the release date, how hospitals abstract, I think you should take into account that many of your members may be outside of the heavy hit areas and are several weeks behind the New York area. So these responses are likely to be much different next month. So it is likely, when we look at a map that shows where our hospital, we have a lot of hospitals. Our hospitals that participate, which is about 90 to 95% of all U.S. hospitals who perform CV surgery participate in our database. We are pretty close to that map that you see on, I guess the saturation of our hospitals is pretty close to that map that you see on the CDC website. So we have a lot of hospitals throughout all of the United States, but I think that's a good point to take into account that not everybody has been hit yet, but we have a lot of hospitals that have been and that we've been hearing from. Shouldn't there be an unknown selection made available for the COVID-19 question? No, the question is, was the patient tested positive, yes or no? So if you did not have a test for a patient, that patient gets coded as no, you did not have a positive test. No, and then this is from Cindy. Thanks, Cindy. No would not be the same as tests not performed. Tests were not available. No documentation in the chart that tests were performed. So we're just asking. The question is not was the test performed. I don't believe the question is. Let me pull up exactly what the question says. Hold on. So the question is, did the patient have a laboratory confirmed diagnosis? We're not asking was the patient tested. We're asking, did the patient have a laboratory confirmed diagnosis? So if the patient did not have a laboratory diagnosis, or the patient was not tested, you cannot code yes. You have to code no to that question. Can these slides be available? Yes. So can these slides be available to us? Our medical director and team would find it really helpful in regards to abstracting the COVID-19. Yes. So as soon as we get, it takes about a day or two to get these up, but I will post the recording along with a PDF set of the slides for everybody. Many of the reductions and collections were simply changes from individual fields to select all that apply. How can this be considered a reduction in the effort of data abstractor? So you are, that's not quite true. So many of the reductions were not. I can show you an example of where an area where we reduced, I think, 40 fields down to like 15 fields. And that was actually in two of the sections. One was in the coronary cabbage grid and the other was in the hemodynamic section related to the CAC findings. Do we code, and we only added a few multi-select fields. Do we code no for patients who have not been tested, or do we leave blank for not applicable? Code no for patients who were not tested, because the question is, did the patient have a confirmed test? What should we do if they are readmitted with suspected COVID-19? So please abstract the readmission fields as what their symptoms were, the reason why they were readmitted, whatever that option may be. And then you would submit that, or you would abstract this as yes, after discharge within 30 days of surgery. When did this email go out in regards to this? Never received it. So it went out probably, or I think it went out around 11 o'clock Central Time. I would check your spam folder. If you did not receive it, you can reach out. It went to primary, backup, vendors, and I believe surgeons on our emails. If you did not receive it, feel free to email stsdb@sts.org or ccrone@sts.org, and we can check into if they go out to you and if it was delivered or if it was blocked. We can look into that for you. I thought your timeline on your original slide stated 8/23/20 for harvest due. I don't think so. I think it says, shouldn't say, I think it says 8/21, but maybe I had it wrong. 8/23 is the opt-out date, I believe. 8/21, oh, so August 21st is the close for harvest date. How many data managers have had mandatory reduction in hours and may need to be pulled as well? Our facility reduced full-time hours for our department to 24 hours per week. Other departments at our facility have furloughed multiple positions. Yep, we're taking all that into account. These are just questions to kind of get an idea of what things were happening at hospitals so we can make a decision. If we continue to submit Harvest 2, will there be a data refresh on our dashboard? So the analyzed dashboard will not be refreshed, but your uploader, your data quality report, and your missing variable report will be refreshed with your new data that you're entering in. For COVID-19 temp field, is there a number answer for no? All the answers I saw were yes. Yes, the first one was no. So that was Harvest Code 10 was no. Can you please send these calls via Outlook so we can save it in our calendars? Working remotely, and this would be great to have in our calendar. Thank you. So I will not be sending out invitations as a calendar invite, but you can certainly add. These are posted on the website. You can certainly add it there. I do believe when they send that email out, if you hover over it or if you go onto our website, you may be able to add it onto your calendar. My computer glitched out when you had the poll for the release of the new form. I had to log back in and did not hear if the form will be delayed. Is it delayed or still targeted for July 1st? This is under discussion with the STS leadership, and we'll communicate out any changes as soon as we have direction to do so. Not all of our patients have been tested for COVID. Will there be some sort of adjustment during the COVID time period for, say, prolonged intubation or reintubation? So as we get that data in and we can see patients who are COVID positive and if they're prolonged vent or reintubation, things like that, we'll be able to make more of a decision. We just really need to get the data in so we can analyze it and make some good decisions. TVAR Go, next question. TVAR Go in STS only if a CV surgeon performs the procedure. Is that correct? Yes. So your surgeon has to be on your agreement with STS in order to enter any cases into the registry. Next question. Do we have to change the value if it falls into the red range? Yes. So you would go to the highest or lowest, whichever corresponds to the closest value for that result. Next question. Regarding the audit, I know I am working from home as many of my colleagues. I don't have access to things that would be needed for an audit as they are at the hospital and/or office. Please give this subject a lot of thought. I am just getting by day to keep the data abstraction process going during this COVID crisis. Absolutely, we are recognizing that, and this information is very helpful because I assume you're probably not the only person who is in this situation. So we need to, STS leadership needs to be aware of all that's going on, so this is really helpful. Thank you. Is Harvest 1 outcomes reports expected to be delayed? So we usually typically have Harvest 1 outcome reports available the end of April. This is the first time we will have bidirectional data exchange with between DCRI and IQVIA. IQVIA is getting ready to send all of the data over to DCRI. DCRI will accept that data in, do the analysis, and then provide back the, using that bidirectional data exchange, provide back the results into the IQVIA system, where IQVIA will display it in the analyze the dashboard. That time frame may adjust right now. We're still aiming for the end of April, and any changes to that timeline will be communicated out. Our surgeons and cardiologists want to use their data for research. They want us to continue to collect true values. Does STS not use data for research? You could still have values for your risk modeling. No, so that's exactly correct. So if you have these far outliers, they're not providing your surgeons any value in their data analysis. So they're so far outside of the normal range. That's why we have to have endpoints for them. Our database does not allow us to enter values less than or lower than the high value. Yay. So that's right. That's what's supposed to happen. Our TVAR cases are done by vascular surgery and are reported into VQI by the vascular data manager. Very rarely, a CT surgeon may assist the vascular surgeon with this procedure. Should that go into STS also, even if it is in VQI? If your STS surgeon who is on your agreement with STS performs a case, it can go into the STS database. Usually the vascular surgeons are performing in the lower, not in the, they're not performing in the arch or the ascending or descending aorta. They're usually performing in the abdominal aorta. So that's what you would want to take into account, is who's performing the surgery. Does that surgery belong into the STS database? And if it does belong, then you should enter it in. Are surgeons worksheets available for version 4.2? Nope, not available yet, probably in June. Do the vendors know about the temporary COVID fields? I am just starting to abstract January charts and do not see where these temporary fields are in my vendor's tool. So your vendor has built all of these temporary fields into your software. You may, these temporary fields are part of each data upgrade that they're in all of the data specs, and they are built into the vendor software. You probably need to look for something that says temporary fields. I would reach out to your vendor to find out where to find these fields at. They are updating these fields to read things. They may be updating, but not required to update what the harvest code displays. So harvest code 10 would be no, harvest code 11. Let me see if I can find it for you. Harvest code 11 would be, I'm on the right-hand side here. Harvest code 11 is yes, prior to hospitalization for surgery. So some vendors will be updating their harvest codes, others may not be, but you just need to abstract according to the harvest code until your vendor chooses or not chooses to update the terminology that's there. The poll answered by those previously audited clearly said 46% extreme burden on audit, which you pulled down quickly and read it out incorrectly as moderate. So I said moderate. I said it was a combination of both of those. It was towards the heavier end of moderate or extreme burden. I did not pull it. I'm sorry if I didn't leave it up there long enough for you to see it, but I did recognize that it was between moderate and extreme. If a patient wasn't tested, then it doesn't matter. It seems correct to assume they are negative. So we're not assuming they were negative. We're asking, did the patient have a positive test? The question is, was the patient tested positive? Not was the patient tested at all and was that test positive? We're asking, was the patient tested positive? So please abstract according to what the question is, how the question is written. In terms of a new version for sites that have to have internal IT download, configure, and integrate the new software into a system, a July date is going to be extremely difficult. For example, at my institution, all IT projects are on hold with no anticipated restart date. So with backup of the projects, if STS goes live in July, the likelihood I would be able to have this downloaded in the time is small. Yet we are recognizing that, and we have been hearing from quite a few sites who have IT now is putting limits on what can and cannot be done, and things are being labeled as emergent only if things need to be accomplished. So we are well aware of everything that seems to be impacting the sites, I think, but it's good to hear this and it's good to pass it on. So thank you for that information. Won't the procedure ID table need to be updated for 4.20? Yep, it's going to be updated for 4.20. DCRI is working on it now. Highly unlikely that there will be any significant change in it. Next question. We have been instructed in the past not to round off the lab values. Now you're stating to enter values that are not truly representative of patients' abnormal outcomes. No. So what I'm saying is that the way the database works and the way data analysis works is that we have to have ranges. That's just a normal thing for how data works. So I'm not saying to round off. I'm saying that you need to, if you're outside of that high or low value, you need to enter the high or low value respectively. This is how databases work. Otherwise, what was happening, if you have been entering values and your data has been accepted in, DCRI has set those values to missing. It has been sent back to you in your DQRs, and some sites have not been adjusting those values, so you lose that risk for that patient. Next question. We'll have to download something from our software vendor in order to now put the data in the temporary field. No, that field should be available. That field is supposed to be available from your software vendors for all of the sites. All of the software vendors need to make those temporary fields available to you when they build a new version. So it should be there. You just probably need to, if you're not able to find it, you may need to reach out to them and ask them where it's located at. If there's no documentation regarding COVID-19 testing, do we leave the temp field blank or answer no? So the question is, did the patient have a confirmed test? So if the patient was not tested, then you answer no, because they do not have a confirmed test. If the patient goes into the OR for CABG after a failed PCI, how should this document be documented in the database? Planned, unplanned to unsuspected disease or anatomy, or would it be unplanned due to surgical complication? So I'm going to see, I believe that this would be coded as planned, not as an unplanned procedure, and then you capture that it was in the, if it was right after the PCI, you would capture the according urgent emergence reasons. But Priya, I'm going to ask you to please submit this into the STS FAQ mailbox so that we can make sure that our answers are consistent with, my answer is consistent with how Melinda has been instructing sites. Please give us examples of what would be CABG, yes, unplanned for unsuspected disease or anatomy. So if your surgeon goes in and they are doing a valve and they notice that the patient has significant coronary artery disease that was not captured on a previous cath, or maybe the patient didn't have a cath, that would be unsuspected disease or anatomy. When looking at an isolated AVR and you have unplanned CABG due to surgical complication, it is still within the isolated AVR. What does CABG AVR with unplanned CABG due to surgical complication include? Do you need to look at the consent for surgery and what is planned? Yes. So it should be it has to be stated what's intended for when that patient enters the OR. The lab test for COVID-19 diagnosis, does it need to be a test for virus, or will antibody tests also count? So we had some specific language about what the testing needs to be, and I'll bring this back, Donna, and ask Dr. Shahian. He provided exactly what that testing needed to be. I do not believe that antibody testing would count. That only shows that the patient was exposed to it and had now built up antibodies. Patients could, I don't know that that would be appropriate, but I'll bring it back and find out, and we can provide clarity on that. Good point. So for the ProcID chart, if it is not in the isolated column, then it automatically goes to the other column. Is that correct? Correct. And if you have a specific example, Diane, that you would like us to respond to, essentially, yes, that is correct, but without a specific example, it's hard for me to make sure I'm providing you the right information. I would send it in to the, FAQ mailbox. That chart is so confusing. So it's a lot better to look at than what we had before, because that was actually really confusing in 2.73. So you just have to look at it as if it's in that column, then that's what's going to keep it in the category. And we will probably do we could probably take that up at AQO to maybe explain that a little bit further. Maybe we can do some, we can get some FAQs in there, and we can look at FAQs that have been coming in about how do I code this chart or how do I code this case, and we can use that as examples for a presentation during AQO. So somebody asked if we could carry over the header for the ProcID charts into each row, and I totally agree with you. It's very hard to read when you're flipping pages. STS doesn't develop that. It's developed by our, it was developed by DCRI. We will have a new one with version 4.20, and I'll try my best to work with IQVIA on, or DCRI on making sure that that header row is carried over. The hospitals that have been hit are probably not on these webinars. That might skew the data. No, I think we've got pretty good insight into what's going on at hospitals, especially what we've heard from some of the hospitals and surgeons in New York. It all pretty much looks like it corresponds to one another. We have just a few minutes left. I'm going to let you see all the questions that are left so you can upload, and maybe I can take just another couple minutes here. Then where can I find the new procedure type tree? So that new procedure type tree has not yet been updated yet. DCRI is working on that now. Can you show the slide with the STAR reporting information again? If this is it. Oh, not too fast. I think it's that one. And you could upvote, if you see the thumbs up, you can upvote on that. Where is the contact list of MDs since the STS report site was taken down? How do I access this information? It's not on the IQVIA website. So it is coming to the IQVIA website. We are establishing a connection with them on our system that keeps track of that, and their system that reported out. It is something that's planned for either phase 2 or phase 3. Regarding COVID-19, when we do call for follow-up, is it enough that the patient tells us she was diagnosed or coded as a yes, or do we need to have a documented test in the chart that was negative, patient never symptomatic? Test was negative, patient never symptomatic. So Beth, I'm not sure, are you saying that patient had a test, the patient was never symptomatic, and then you called the patient for a follow-up and they're saying that they were COVID positive? I think we need to have a positive test for that patient, but I think that's a really good question, and I can bring it back and we can get clarity on that. For the upgrade, it is not just the reduction of fields, it's everything else. The frequent communication with the vendors, looking and reviewing the customization of the DCF, the reviewing of the forms, and the overall time taken to get to the upgrade up and running, difficult as it is doubly difficult from home. So yep, totally recognize that, and hopefully these webinars that we're doing for the upgrade are helping. It's something that has never been offered before for any of the upgrade. So hopefully you're going to feel more comfortable with this one, but I understand the stress that it's causing. Should we call patients that have already confirmed 30-day status on for surgeries from January 1st on and rescreen for confirmed COVID-19 within 30 days of their surgery? Surely that's completely up to the sites if they want to take that extra step. STS is not going to enforce you to call patients to confirm the 30-day status for patients that were done back in January. But I think if you want to get the full view of how your patients are doing after surgery, it's okay to do it, but we're not going to enforce that for cases way back then. Years ago, there was a ProcID tool that, ProcID algorithm tool, aside from looking at the chart table. Will there be something similar to that, and will it be available in the near future? No, no, there will not be. Does the STS want TAVR cases submitted if surgeon is not present for the procedure? So the STS ACSD registry does not require TAVR cases to be submitted to our registry. If you choose to enter them, then that would be between you and your surgeon and your quality department. Next question. So I'm going to take, I guess I have 3 more. I'll take the next 2 and then we'll go from there. I believe the 30, then we'll probably end the call. I believe the 30-day call question referred to patients reporting that they were COVID positive. Do we take their word for it or do we need to see the lab report? They may have been tested positive outside the hospital. So as I said, I'd be happy to provide more clarity on that. I have to check with the surgeon. Does the STS want to have our cases submitted if surgeon is not present for the, I already answered that one. And I think, so I agree with Cindy that who said no coding no to the COVID question is not the same as the test not performed and are therefore no documentation in the chart. So the question is, did the patient test positive? It's not did the patient have a positive, it's not did the patient, was the patient positive? The question is, did the patient test positive? So I'm sorry, I'm saying that wrong. The question is, did the patient test positive? We're not saying was a test performed. We're saying was it test performed and the test was positive. So read the question that's on the data collection form and answer the question. I totally agree that no is not the same as the test not performed, but that is not what we're asking. We're not asking if a test was performed. We're asking, was the test performed and was that test positive? Okay, and I think that we're going to end here. It's 2 minutes after. If there's anything specific that you need, please submit it regarding, if it's regarding a case, please submit it into the STS FAQ mailbox. Otherwise, we will see you again coming up here. I think on the 15th is our next call for the user group. So thanks everybody for joining. Really hope that you're staying healthy and well, and please take care of yourself. Thank you.